hope today is to cover the recent changes in the Public Health Code, some new change to the Drug Enforcement Administration regulatory regulations, and then look at some of the legislation that is being discussed here in Lansing and how it will potentially impact pharmacists in our practice. And then lastly, if time allows, to look at some of the most frequently asked questions, things that we receive here at the office from pharmacists, from technicians, from practitioners related to laws and regulations regarding the pharmacy practice. We've already covered the objectives, so I will not reiterate what was already stated and move right on to our presentation. Just wanted to share with you that yesterday the Drug Enforcement Administration, through the release of the Federal Register, announced that carisoprodol, most people will recognize it as Soma, a drug that was first introduced onto the market in 1959, is going to become scheduled as a controlled substance. It will be a C4 drug. This becomes effective January 11th of 2012. Because it was announced yesterday with the effective date of January 11th, that gives the DEA their 30 days notice required.
It says I lost audio connection. Keep going.
And so as a reminder, effective January 11th, all pharmacies that have in possession carisoprodol will have to include this on your inventory, as well as then start reporting all prescriptions dispensed for this drug on the MAPS program. One of the interesting things, or one of the things that I tried to find out is what is the status of prescriptions that you currently have related to carisoprodol. Is that how many refills yet would there be allowed and such, and it's not addressed in the Federal Register. So in the next few days, we will be trying to resolve this with some answers from the DEA. So moving on, let's discuss Public Acts 84, 85, and 86, which were signed into law in July of this year and become effective January 1st, just less than a month away. And this deals with the sale of products, pseudoephedrine, at retail. It will require for all vendors, not just pharmacies, but every retail vendor that sells the pseudoephedrine products to record the sales and transmit sales data on the NPLEX database. And NPLEX is an acronym for the National Precursor Log Exchange. The other impact of this change or changes to the Public Health Code is, as you'll recall, currently pharmacists or retailers are limited to selling 48 tablets or capsules per sale to an individual. That has been changed, and now it's going to comply with federal standards, limitations of 3.6 grams per day, 9 grams per 30 days, or a rolling calendar. And by utilizing this software, this database, since it is a national database and 17 states have already adopted it, you will be able to get instantaneous feedback once entering into this database, whether the individual purchasing the drug from you or attempting to purchase, let's put it that way, has maybe purchased from the pharmacy across the street or the convenience store or the grocery store, or if you're in a border city and say this individual was in South Bend, Indiana, purchased 3.6 grams, the total amount possible per day, and then they crossed the state line, went into Niles, and attempted to purchase again, you would get immediate notification whether this person has complied with or already exceeded the daily amount. The software is being provided by the National Association of Drug Diversion Investigators to all vendors. Now, I apologize for this slide, but I just wanted to share with you that at some time this week, you will be getting a letter from the Michigan State Police. They are sending a letter to each and every pharmacy, as well as to all retailers, grocers, convenience store owners and such, advising them that effective January 1st, the utilization of the database is required. And that in this letter it states that you must be signed up with the vendor by December 28th. There is a website, it's nplexsurvey.com, and such. So if you have not received it as of yet, look for it this week. Again, it's coming from the Michigan State Police, and they will be the agency that is overseeing this program. As stated, Michigan joins in this program. There is a website for the National Precursor Log Exchange. On the slide there you can go to this website, nplexservice.com. It has some frequently asked questions for pharmacies, also for law enforcement. I would suggest that you review this within the next couple of weeks. Now, for those pharmacies that do not retail pseudoephedrine, you only will dispense it via prescription. If you have made that decision, you are required to notify NPLEX that that is the method in which you dispense pseudoephedrine, and from that time then you would not need to worry about this website program. So again, I would urge you to look at this, be on the lookout from the letter from the Michigan State Police, and be appraised that come January 1, this is going to be the law of the land. It's unfortunate the law was adopted and signed by Governor Snyder in July, and it has taken this long to get information out to all of the pharmacies and all of the other vendors. And we had tried time and time again, and working with the NPLEX, with PRE, which is the database company, with the governor's office, and such, asking them to please get information out as quickly as possible. And for one reason or another, their government works slowly, and unfortunately, that has led to the failure of getting out the information appropriately, and we caution them with everything else going out this time of the year and upcoming changes effective in January for other programs and such, that they needed to get this out as quickly as possible. However, it is what it is, but I would like to urge you to look at this and be aware. So a patient presents to you a prescription for pseudoephedrine 30 milligrams, 180 of them, and it is written for 1 or 2 tablets every 4 to 6 hours for allergic rhinitis. What are your requirements under the new law regarding the sale of pseudoephedrine products on the prescription? A, fill the prescription, no further reporting is required. B, report to the NPLEX database. C, document the bound logbook. Or D, none of the above. And the answer is, it's no different now with the electronic database as previous with the written log, is that you fill the prescription and nothing further is needed to be required. You do not have to enter it into the electronic database. Prescription is considered a separate transaction. It's not the retail sale of an over-the-counter item, and therefore it is exempted from the requirement of reporting this via the database. Hopefully, when you do your post-test, everyone will get this question right. So let's move on. Public Act 155 was adopted again this summer. And this really impacts, for the majority of the pharmacists that are close to the border states of Wisconsin, Indiana, Ohio. But what this Public Act did was it changed the section in the Controlled Substance section 7405, and in the Pharmacy section 17708 that defines a prescriber for out-of-state and who a pharmacist can fill for, or what controlled substance prescriptions pharmacists can dispense when written by an out-of-state practitioner. And it has been expanded to include dentists. So now there are 3 professions that can prescribe: a dentist, a physician who is either an MD or a DO. Please note, this does not include any prescription written by a mid-level practitioner. And this was done specifically because we do not know what are the regulations for all mid-level practitioners throughout the country. If there are limitations, are there limitations as to what they can prescribe? Are there limitations to quantities, such as what Michigan has with certain mid-level practitioners and such? So it was decided that it would be specific for dentists, physicians who practice either the medicine or osteopathic medicine. So again, I'll look at, you receive a prescription for oxycodone 10 milligrams, number 20, and it's for 1 tablet every 12 hours, written by Dr. I am in pain, and he's out of Marinette, Wisconsin. Can this prescription be dispensed by a Michigan pharmacist? And your choices are: you can only dispense out-of-state controlled substance prescriptions written by an MD or a DO. Can dispense out-of-state controlled substance prescriptions written by an MD, an OD, or a DDS. Can dispense out-of-state controlled substance prescriptions written by an MD, a DO, a DDS, or a DMD. Can dispense out-of-state controlled substance prescriptions by an MD, DO, or a DVM, Doctor of Veterinary Medicine. And hopefully everyone recognized that the correct answer is C, as in cat. You can dispense out-of-state controlled substance prescriptions written by an MD, a DO, or the 2 designations for dentists are either a doctor of dental surgery or a doctor of medical dentistry, and DMD. So answer C is your correct one. And again, for the post-test, you're at 67%. We just need 3 more percent to get a passing grade for completion of this program. So let's look at Senate Bill 384, and this actually was just recently signed into law. And forgive me, I do not remember what the Public Act is, but this bill and Public Act changes the ability of physician's assistants to prescribe Schedule II controlled substances. It supersedes the rules of the Board of Medicine and the Board of Osteopathic Medicine and Surgery, and eliminates the restrictions to the quantity and location. As you'll recall, that for physician's assistants under delegation, there were only 3 methods or areas in which a PA could prescribe a controlled substance Schedule II medication. It was if they were discharging the patient from a hospital, if they were discharging them from a long-term care facility, or from hospice, and they were limited to a 7-day supply. Under this change in the Public Health Code, there no longer are restrictions on the quantity nor the location from which a physician's assistant can prescribe a C2 substance. So from their office, from a clinic, if it's a narcotic or sympathomimetic, they are allowed to prescribe that as long as they follow the rules related to the pathomimetics. But the law is specific. It requires the name of the delegator and the delegatee on the prescription. And we made certain that this language was added to the public health code to hopefully help the pharmacists out in practice, so that when they are questioned, they can tell the physician's assistant that yes, it's required by law, and it's in the public health code, and it said you have to have both names on the prescription. Also, that both DEA registration numbers, that of the delegating prescriber as well as the delegatee, have to be on the prescription. And then furthermore, it requires the name of the prescribing individual on the prescription label. And this was done really to avoid confusion for the patients. It was requested by all the mid-level practitioners specifically that they wanted to make certain that when the patient did the prescription label, that they knew who prescribed the medication for them. And in some instances, the physician's assistant may not necessarily be in the same office as the physician, or in an urgent, it could be in an urgent care setting or such. And if the patient sees that PA or nurse practitioner, because this would apply to their prescriptions also, it's important for the patient to see who actually prescribed this medication for the patient. So if your software does not allow you to do this, or does not transmit the mid-level practitioners, please talk to your software vendor and such. So as I said, the name of the prescriber or the delegated prescriber is to appear now on the prescription label. So prescription, a patient presents to you a prescription for oxycodone 10 milligrams, again, number 20, with the directions to take one tablet every 12 hours, PRN Pain, written by Pain No More, who's a physician's assistant, and he's writing this from his office. The prescription form identifies the delegating prescriber, includes the DEA registration number of both the physician and the physician's assistant. The question is, can a Michigan pharmacist dispense this prescription? Your choices are A, only if the prescription is signed by the delegating prescriber. B, only if the prescription is written when discharging the patient from either a hospital, freestanding surgical center, or hospice. Or C, only if the quantity does not exceed a 7-day supply. Or D, yes, this prescription is valid and as written. And as just stated with the new law, the correct answer is D, this prescription is valid as written. It complies with all the requirements of having both names on the prescription, both registration numbers, and it can be now prescribed by this physician's assistant out of the office setting. So I've been getting questions now from individuals related to, well, why is this physician assistant specific? And I will tell you that when the bill was originally introduced, it did include nurse practitioners. And at the request of the Michigan Council of Nurse Practitioners, they asked to have their names stricken from the bill. They wanted it amended such that they were not included. Part of it dealt with the fact that in the legislation, it really would have placed them under the boards of medicine, the boards of osteopathic medicine and surgery, and the nurse practitioners obviously did not want to come under the boards of medicine or osteopathic medicine and surgery. They want to retain their own autonomy. And additionally, what they had already being drafted were two pieces of legislation, Senate Bill 481 and House Bill 4774. And I will tell you that both pieces of legislation are identical. They are having it introduced in both chambers with the hope that it will move through quickly and will be adopted. And basically what this legislation does is create independent practice for nurse practitioners. They would no longer be prescribing under delegation, and they would have no restrictions. And as the governor last year, or I'm sorry, earlier this year, I'm already thinking that since the legislature is leaving, we're into next year already, pardon me. But as the governor spoke about access of care, wanting to increase the number of primary care providers, and he talked and addressed about the greater utilization of nurse practitioners, they feel that they have support from the governor's office. So they've introduced this legislation, and as we've reviewed it, we have two issues related to the legislation. One is that because they would be changing or including advanced practice nurse, nurse midwife, under the definition of practitioner or prescriber, this would then allow them to qualify for a drug control license. And we feel that, as you know, any dispensing prescriber, they're dispensing something other than complementary starter doses, that is samples, must have a drug control license, and then they can dispense prescriptions as long as they comply with all of the pharmacy regulations. And we felt that, we still believe that even for physicians to do this is wrong. Not so much because we're protecting turf, but because we're protecting the patient. We feel that there needs to be a second set of eyes that look at these prescriptions and make certain that they are written correctly, appropriately, and in the best interest of the patient. So that is one issue. The second issue is that as we look at this legislation, there is nowhere in there a definition of the scope of practice for advanced practice nurses. And again, we raised issues with this because it is, again, you're well aware that pharmacists, your responsibility, your corresponding responsibility is to dispense prescriptions within the scope of practice of the prescriber. And without knowing what that scope is, we just felt that it was inappropriate for it to be written so broadly and to give them carte blanche. And there may be instances in certain areas where a nurse practitioner can appropriately prescribe a chemotherapy agent, but that may be very limited, and maybe in a setting where they are practicing in a medical institution, in a oncology clinic or such, may be appropriate. But someone that is in a general practice and such, maybe not so. And we just felt that there needs to be some definition, some scope of practice identified now in this legislation. So what have we been able to accomplish? They being the Michigan Council of Nurse Practitioners, as well as the sponsor in the Senate and the House, that they do accept our amendment that would exempt nurse practitioners from being able to obtain a drug control license. And they are seriously contemplating requiring some scope of practice in their understanding the plight and maybe in some cases having restrictions related to what they can or cannot prescribe. The other issue and concern with this legislation is, even though it addresses advanced practice nurses, clinical nurse specialists, nurse midwives, if you look at the language and really study it hard, and the nurse practitioners will admit this, if this passes, it is not all inclusive to practicing nurse practitioners. basically it's saying that they have to have certain amount of education related to pharmacology, therapeutics, and such, that is now being taught in the Doctorate of Nursing program. And so there would be two levels of nurse practitioners. And I know from the number of phone calls I get from pharmacists, from the number of phone calls I get from nurse practitioners challenging their ability to prescribe certain drugs now because they have that DEA registration. This would just open up a whole new set, can of worms and issues for pharmacists. So again, as we're looking at transition, this is another area where it could really offer some issues for pharmacists. So what other transitional legislation is out there? Well, we have a bill in the Senate, Senate Bill 591, introduced by Senator Green out of Bay City, that would require the licensure of pharmacy technicians. It would also require some type of certification and or some establishment of minimal competency, whether it was board-approved training programs or such. So we are watching this legislation. There's been no action taken on this legislation because the state legislature, the Senate in this case, has been waiting to see what is going to come out of the committee that was initiated by the governor, his Office of Regulatory Reinvention. And the governor's office is not opposed to this requirement. It was something that was suggested by the governor-appointed committee, the Drug Control Advisory Commission. I'm sorry, I was having a momentary lapse. As well as the Department of Community Health had made this recommendation to the governor's office. And in the recommendation, they were talking about requiring technicians having to attain an associate's degree through this, one of the colleges of pharmacy. And that has led us to look at other means to attain this minimal competency. In the legislation, there is also a grandfather clause for anyone that is currently employed in a pharmacy, and as long as they stayed employed in the same pharmacy or under the same ownership, they would still be required to have a license, but they would be exempted from the certification. The legislation states that the cost of the license would be $20, and it also states that a pharmacy technician would be added to the Board of Pharmacy in place of a public member. It would actually give them a seat on the Board of Pharmacy. So this coming winter, we will be watching this to see where this legislation goes. Senate Bill 735, introduced by Senator Whitmer out of Lansing, would states that a pharmacist would have to dispense prescriptions without bias. And basically, the intent here is to require pharmacists that if, because of moral or ethical beliefs, they choose not to dispense certain prescriptions, that they assist the patient and by either obtaining the prescription for them, finding another pharmacy that will dispense the prescription for them, or contacting the physician to obtain a different medication or such, but to take care of the patient. It also states, hard to believe, but it's resulted in this language, that the pharmacist, if they will not fill the prescription for whatever reason, that they must give the prescription back to the patient. And this actually, and unfortunately, is due to an incident that occurred in a pharmacy where a patient came in to get a prescription filled. The pharmacist said for religious beliefs, they do not dispense those medications. They would not assist the patient finding another pharmacy, would not obviously order the medication, but lastly took the prescription away from the patient and such. So, you know, what has resulted is legislation to mandate that pharmacists do the right thing. The third piece is Senate Bill 789, introduced by Senator Rick Jones out of Grand Ledge, a Lansing suburb here, that would give powers to the Board of Pharmacy to temporarily schedule drugs. And this is really an attempt to give some control or to look at some of these designer drugs that are coming out either on the illicit market or through some channels either obtained from overseas or what have you, but you know, they're not addressed in the current public health code, they're not addressed in the pharmacy rules, and with the rules process being so complex and time consuming, this would give the board the opportunity to, with 10 days notice, have a public hearing to name a particular substance as a controlled substance, and then it would be temporarily scheduled as such for 180 days. It would then allow them to extend it for a second 180 days, and with the hopes that in the process either legislation can be passed to make these drugs either illegal or scheduled, or for the Board of Pharmacy to promulgate rules to do so. And in case you're wondering, the Board of Pharmacy does have that authority to regulate medications to either make them controlled substances and or even a prescription item, regardless whether they're over-the-counter or such. So this is been newly introduced, and we will see where how fast this will move. Not to be outdone, the House Chamber has introduced 4 pieces of legislation, and one of which may already have been taken care of by the announcement by the DEA yesterday, but Representative Brown out of Oakland County introduced House Bill 5056 that would have scheduled soma as a controlled substance Schedule 4. So she was already looking at some of the abuses and problems that seem to be occurring or have been occurring for a long period of time, and after consultation with MPA decided to introduce this legislation. We will encourage them to continue to pass this so that it will appear in the public health code, and we know that in the proposed rules that the Board of Pharmacy has introduced, they too were recommending making soma carbidopa a Schedule 4 substance. So it seems that you know, all 3 entities, the DEA, the legislature, and the Board of Pharmacy, have looked at this and their concerns about the use of this drug or the appropriate use. The next 2 bills, House Bill 5089 and 5090, are tie-barred, which means that in order for one to be enacted into law, the other bill must also be enacted into law. So it's all or nothing. The first bill, 5089, introduced by Representative Johnson, would create a drug repository. And as you know, we already have a cancer drug repository program in the state. This goes beyond it. However, it does have limitations. It limits it to only drugs that are in the possession of a pharmacist, a physician, a licensed healthcare provider, or a manufacturer. And these drugs have to be within date, unit dose package, or unit of use. And then they can be donated to a charitable clinic, but that charitable clinic has to have a licensed pharmacy. And that a pharmacist would review these drugs, make certain that the drugs are appropriate as far as the package, have been stored appropriately as best as one could ascertain, and that's why it's limited to just healthcare providers, and then they could be redispensed for indigent or Medicaid patients. The bill is tie-barred with House Bill 1590, which is introduced by Representative Ananich, and Representative Ananich is out of Flint, and this one mandates that if a clinic or a pharmacist participates in the above drug repository, and by the way, this drug repository is a voluntary program, so no one's mandated to, it just makes it available. But if you choose to participate in this program, you are obligated to take back any medication that is brought into the pharmacy from patients, family members, or such, and to dispose of them appropriately. And this has some concern for us because sometimes the costs of taking back these medications and appropriately disposing of them may be more expensive than the good that is done by participating in this drug repository program. So we are going to continue to monitor these, but again, they're both, well, the one with the drug repository, it's a voluntary program, but if you choose to participate in that, you must then dispose of all other medications that are returned to the pharmacy. The last bill that we are watching is House Bill 5131, introduced by Representative Liss out of Warren. And Representative Liss is a nurse. She's a registered nurse. Previously, before coming to the legislature, worked in the emergency room in Henry Ford Health System. And in that, this legislation is termed really a transition of care legislation that would recognize or allow discharge medication orders be utilized. Specifically, its intent was for the long-term care pharmacies to utilize these discharge medication orders as a prescription, so that when that patient is transitioned from a hospital to a long-term care facility, those orders can be then processed as a prescription to get the patient started on their medications in their new residence until such time as the attending in the long-term care facility would come in and check the patient and rewrite the orders appropriately for that long-term care medical institution. This has been a significant issue for hospitals now, with patients returning or being returned to hospitals for medications. They've been discharged, sent to a long-term care facility, and because of the length of time sometimes it takes for the physician to come around to write those orders, or now with the DEA looking at these controlled substance orders and really scrutinize how they're being written and transmitted to pharmacies. This is meant to take care of the patient, help the patient, and also help the pharmacist. And the intent is, again, that if this is in the public health code, then the insurances cannot deny that these are not official prescriptions or valid prescriptions because they are written on a medication order sheet as opposed to the 4x6 medication or prescription order. Included in this legislation, we made the suggestion, and they adopted, we put in language as to what if the pharmacist can change on a controlled substance prescription. And we did that specifically because the DEA has waffled back and forth. One time they said pharmacists could change certain elements on a controlled substance prescription. Then they said, well, this only applies to Schedules 3, 4s, and 5s, and not to Schedule 2s, that a pharmacist cannot change anything on Schedule 2 substance. Lastly, they said, well, pharmacists can change certain elements on a Schedule 2 substance if their state jurisdiction identifies it in the public health code. And we thought, in view of all the issues with certain audits and other entities and issues, that if we put it in the public health code, this would best define it, make it easier for pharmacists to know what they can change, what they cannot on a controlled substance prescription, and hopefully stem some of the issues with prescription audits. So those are the things that I see as, having a transition or impact on pharmacy both this last year and potentially this coming year. And as you can see, some of them are very, very good. Others, I think, may cause more problems if not further defined or explained and such for pharmacists. So hence, we're in a state of transition. So moving on, I just wanted to go over a couple frequently asked questions and comment on a couple things in the remaining 15 minutes. And I may not cover everything, but in your handout, there's material, and hopefully just by reviewing it, you will get the gist of what I was going to say. But the one thing I wanted to stress, because as you know, Michigan, and currently Southeast Michigan, has been really in the spotlight looking at fraud and abuse under Medicare and Medicaid. And I wanted to remind pharmacists that, that the Controlled Substance Act is a unique piece of legislation. It's federal, it's a federal act, and it's a criminal law. And so it stipulates acts pertaining to controlled substances that are permissible. And that is the most critical thing. It tells you what you can do. Unlike the Michigan Public Health Code, which is kind of open and tells you more or less what you cannot do, the federal law specifically tells you what you can do. And so if the Controlled Substance Act does not explicitly permit a certain action related to controlled substance, by lack of this explicit permissibility, the act is prohibited. And this was published in the Federal Register back in March of 2010, so almost 2 years ago, but it bears repeating and such. So as you know, all pharmacists, the one thing that we did learn is when state and federal regulations butt heads, one versus the other, that one may be more stringent than the other, and it's always the more stringent that takes precedent. And that under federal regulations, they say the pharmacist should make sure that they understand their state and DEA controlled substance regulations. And I think all too often we kind of forget what the Code of Federal Regulations says and what are maybe their limitations, or specifically what it tells us we can do and how things are restricted. The other is that in the CFR, it is very specific, where it talks about prescription for the issuance of a controlled substance or the dispensing. It must be for a legitimate medical purpose by an individual practitioner acting in their usual course of his professional practice, his or her. And the responsibility for the proper prescribing and dispensing of controlled substance is upon the prescribing practitioner. However, and this is a big but, a corresponding responsibility rests with the pharmacist who fills the prescription. So to say, well, it was a legitimate prescription, it was written by a physician, they have a license in Michigan, they have a DEA license, even though you know it's coming out of a prescription mill, and you see the same type of prescriptions from multiple patients coming into the pharmacy and such, and you have to wonder, are these for legitimate reasons? You have that corresponding responsibility to make certain that it is a valid prescription. And then, that it states right in the Code of Federal Regulations that that prescription must be dated and signed on the date when issued. We know that a lot of times physicians, prescribers do not date that prescription. When you receive it, that's one of the elements that you can add to it. But know that that prescription, if it is presented to you, must be manually signed if it's for a controlled substance. Electronic signatures are not in vogue right now, in that no pharmacy, to my knowledge, has received approval for their software, and I've yet to get validation that physicians anyone has had their software approved, so that any prescription that you receive, whether it's typewritten, computer generated, in the case of a fax to a fax, for schedules 3s, 4s, and 5s or such, they must be manually signed by the practitioner. Stamp signatures are not valid. It must be manually signed. So again, I just included the definition of sign is found in the Public Health Code, Michigan Public Health Code. And I get questions from pharmacists all the time, and specifically it's after the fact they're being audited. And they asked me, they said that the insurer is looking at their prescriptions and they're saying that these are not valid prescriptions. The pharmacy receives a prescription similar to one that you see there for lisinopril, 20 milligrams, 30 of them, 1 daily with 6 refills. It's Dr. Karen Jonas that is the prescriber, but it's signed using the doctor's name by her MA or RN, and just, you know, it indicates that that particular individual wrote this signature and put their initials on there. We see this, I saw it always in a medical institution where physicians would call in prescriptions to the pharmacist, the nurse, or the PA, and they would write the order in the chart, and take it as a verbal from Dr. Barron, signed with their initials, GJB, and we accepted it. But in the medical institution, we knew that that physician was going to round and they were going to co-sign these charts. Well, that fax or that prescription piece of paper such that you receive with signatures such as this is not going to be a co-sign. And since state law and federal law, if this were for a controlled substance prescription, does not allow a prescriber to delegate the use of their signature to anyone else, means that this is invalid. And for an auditor from an insurance company to come through and look at this and see this, to them it's not a valid prescription, and appropriately so, and they can recoup all monies for this. It must be signed by the practitioner. The only other way around this would be for GJB if they were delegated prescriptive authority by the physician and they signed it under their name as a delegated act of the prescriber. And then you have to be cautious whether it's a controlled substance or such. But in instances such as this, it must be signed by the prescriber. So in your handout, I have included this table as to what type of signature is required for paper prescriptions, if they are sent fax to fax, computer to fax, or computer to computer for schedules 2s, 3s, 4s, 5s, and for non-controlled substances. Hopefully you can use this in your pharmacy as a reminder for yourself and colleagues. Additionally, put together a chart that lists what is required under the Controlled Substance Act, that's CSA, for the various schedules with registration, what records are recorded or required, prescriptions. Currently for Schedule 2s, it's just a written prescription. Schedules 3s, 4s, and 5s, it's written, oral, or faxed. Electronic, hopefully, once we get the vendors approved. And remember that in your pharmacy, until you receive notice from your software vendor that says that your computer system, your software, has been approved and complies with the DEA regulations for the e-prescribing of controlled substances, you cannot receive controlled substances electronically. regardless of whether the physician's system has been approved or not, your system has to be validated first before anything, before you can start accepting electronically prescribed controlled substances. So again, this chart is in your handout. I also wanted to touch on fax prescriptions. And contrary to Michigan state law, which allows computer to fax machine prescriptions and such, and using an electronic signature for controlled substances, here the DEA, the CFR, is more stringent. And in their March 2010 Federal Register, when they were talking of electronic prescribing, they made it very clear that fax prescriptions to them are nothing more than written prescriptions transmitted over phone lines, and they are not electronic signatures, and therefore it is not permissible to for anything other than a manually signed prescription. It is not permissible to electronically generate and fax a controlled substance prescription without the prescriber manually signing it. I know it's going to be an issue for pharmacists with prescribers, but please share with them that according to the CSA and the corresponding responsibility, that these are not valid. We are quickly running out of time. I have about 5 minutes. There are just a couple other pieces that I wanted to just talk about. Agents of the prescriber. The DEA put out recommendations for physicians, for prescribers, that if they are using someone to transmit controlled substance prescriptions to a pharmacy, that they highly recommend, they don't mandate, but they highly recommend that a physician name an agent and such. Secondly, I get comments from pharmacists or questions asked, can a medical resident write a controlled substance prescription? Are they valid? As you recall, medical resident is a graduate, they are a licensed physician, they're just doing extended training in a residency program. So as long as they have a state of Michigan controlled substance license and either their own DEA registration number or they are using the DEA registration of the residency program, they can write controlled substance prescriptions, and they must include that DEA registration number along with an identifying suffix on that prescription and the telephone number, some mechanism for you to contact them. Also, it's an obligation of the institution which the resident is practicing in their residency program to make this list available to any registrant that wishes. So, and it has to be available 24/7, 24 hours a day, 7 days a week, so that if you have a question and need to have some type of information or get in contact with them, someone at this hospital, be it the pharmacy, the medical administration office or such, would have this information and can provide that to you. Suboxone Subutex, off-label use, again, questions arise. Can this be used by a physician that does not have the DEA-X number? The DEA-X number is only utilized when a prescriber is using to treat for addiction, and then when they prescribe those prescriptions, they have to have both DEA registration numbers, their regular DEA and that ex-DEA. They cannot delegate this to anyone else, so their PA or nurse practitioner cannot write for Suboxone or Subutex for detoxification and such. However, they can write for off-label use, such as for the treatment of pain. I would urge you and recommend They can clarify these prescriptions and document on the prescription that is being used for pain.